Thank you, Dr. Virender. Good afternoon, everyone. So I'm having this interesting case here. This was a 21-year-old male who complained of pain and vertical diplopia, binocular diplopia, since 3 days. His best corrected visual acuity was 20/20 in both eyes. So at presentation, if you look at his 9 gaze picture, he has a -2 elevation limitation uh, in the right eye, and that is leading to an RHOT of 6 prism diopters. So I'm just going to tell salient positive findings here. So we did a B scan wherein you can see soft tissue thickening with, possibly a ruptured scolex. You can see the multiple high reflective echoes here in the superior temporal orbit as the arrow is showing. And we went ahead and did the CT scan, which, if you can see, the yellow arrow is showing some area of, in the right orbit, right? And you can also see it in the sagittal cuts as well. So we thought this is possibly, a swelling in the lacrimal gland region, possibly a dacroadenitis, and an oculoplasty consult was taken as well for it, and we decided to start on Indocap SR. The patient came back to us a week later. As you can see here, the elevation limitation has worsened. It's become -4 with an RHOT of 30 prism diopters here. So we also closely looked at him further and saw that he has a swelling which was very obvious now in the right lacrimal gland area. So we were thinking, what could be the possible diagnosis? Was it a dacroadenitis, or, like our B scan indicated, was it really a scolex which had ruptured? So what we did was started him on oral albendazole, 15 milligram per kg, and oral steroids. So oral steroids would help in either way. If it was a dacroadenitis or a ruptured scolex, the oral steroids would help. So that was our thought process, and that's what we started. So if you see here, a month later, he had improved. His extraocular motility was full and free, and he was diplopia free as well. His vision all throughout was 20/20. We also got a B scan repeated at this stage, and you can still see a small cystic lesion as the yellow arrow indicates. And that's why he was switched to ivermectin, and he was also kept on low dose oral steroids. The story doesn't end here. He came back 2 months later with a -3 abduction limitation in the right eye. So we got an MRI brain with orbit with contrast done, and as you can see here, it shows a granulomatous lesion in the right cavernous sinus extending till the orbital apex. At this stage also, his visual acuity was 20/20. We further went ahead with certain investigations. The CBC showed leukocytosis, ESR was raised. The Mantoux test was positive. Other things were all normal. Chest X-ray, IgG4, and serum ACE were all normal. So at this stage, we thought, let's revisit the history. He had a history of being treated for primary complex at the age of 4 years. So the point is that at this stage, you can't take a biopsy for such a lesion. So based on the presumptive diagnosis of tuberculosis, we also took a pulmonology consult and started him on oral ATT, and along with that, oral steroids. So presently, we don't have the last follow-up, but I have spoken to the patient. He's gone to Bangalore. He's following up with our plastic colleague who's there in Bangalore. So he's good. He has no diplopia. His extraocular motility has improved. So that is his current status. Vision-wise, he is 20/20. So that is his current status here. So the take clinic message here would be that such cases, the diagnosis is usually not straightforward, and because it's difficult to obtain the samples here for biopsy. So you'd essentially rely on the tuberculin test, Mantoux test, the chest X-ray findings, and the past history. And treatment would be a combination of ATT and oral steroids. Thank you.
Dr. Snehal, that was a very interesting case. So, are the steroids still continuing, or they have been tapered off?
Now they're tapered off. It's been quite some time now.
And Was there any reactivation of the primary focus in the lungs or anywhere?
So there wasn't any primary focus per se, like the
Oh.
chest x-ray was clear. So,
Okay.
and this was just a presumptive diagnosis, so, and he responded well to the therapy.
Actually, we did a HRCT at that
Mhm.
time, and the HRCT showed the signs of consolidation in the upper lobe. So it was means not the consolidation, the signs of old tuberculosis,
Tuberculosis.
Nothing active.
nothing active.
And how long was the duration of the steroids in the first time when you had treated and he came back with
So,
a recurrence?
he was, yeah, yes.
So full dose. You would require full dose therapy before we start tapering, and otherwise you tend to get a recurrence. But it's interesting that so let's hope that your presumptive diagnosis, it's like a therapeutic trial now, that if it doesn't come back on ATT,
No,
then
he's
only.
fine. I spoke to my colleague who is
And
at Narayan Netralaya. He's following up there.
so
He's good
how
now.
so
It's
I
been
mean, the
quite some
worry is
time,
after you
6
stop
months.
steroids
Yeah.
and then he shouldn't come back, then
Yes.
your tuberculosis or presumptive tuberculosis diagnosis is appropriate.
Yes.
Else it could be, you know, if it
Something
comes back
else.
again,
Correct.
then the all the recovery was because of the steroids and not because of
Yes.
the
ATT.
ATT. So very nice, interesting. Look
Thank you.
forward to more, how the
Thank
patient
you.
goes on. All the best for
Thank
that.
you.